Hello, welcome everybody. Thank you for registering and attending this glaucoma seminar, KKESH based on Bleb Uptopia 2020. And I'm very pleased to welcome Dr. Ike Ahmed with us today, who spared his time. And he's really one person who needs no introduction whatsoever. He's the Division Head of Ophthalmology at Trillium Health Partners in Mississauga, Assistant Professor at University of Toronto, Clinical Professor at University of Utah. He's regarded as a clinical innovator and leader in ophthalmology. Consistently, he's been voted top 10 in the ophthalmology power list, and he has around 11,000 subscribers to his YouTube surgical channel, which I'm sure we're all familiar with. And affectionately, he's known as the rock star of ophthalmology, and we can all see why. And helping him today, we have Dr. Ala Mufti, who is currently the Glaucoma and Advanced Anterior Segment Fellow working with Ike. Ala is a familiar face to us. He's a KKESH Fellow graduate of 2018 and did a second fellowship with Hardy Saib in McGill and currently doing a fellowship with Ike. So thank you very much, Ike. Over to you.
Thank you so much. I wish greetings to everybody. Assalamu alaikum to everybody. It's been a while since I've been to KKESH. We were just thinking it's been about 6 years, and it's still very, very fond memories in a very special place. So thank you for inviting me. I know we have a short time, so I will get started. I am very pleased to share the stage with one of my fellows, Ala Mufti, who you mentioned. Ala is, as you said, a KKESH graduate, Saudi national, who has done 2 fellowships in Canada, so he is very well trained. We're very proud to have our first Saudi fellow that has joined us. And I think that Allah now, after spending this time here, I think is very well trained and ready to get back to action in the home country. So I hope you will receive him with open arms and collaborate well. I'm sure it will be a great experience. I'm going to start off this webinar, and we've titled this maybe somewhat provocatively for Bleb Uptopia. And most of the time when we talk about Blebs, we don't always talk about Utopia. We talk about sometimes the challenges. But what I hope to go through today is basically some tips and some tricks and some thoughts just around the Bleb. And I will start off with my disclosures, of course, and I will start off with a little bit of philosophy, quoting from Shakespeare. As you know, the very famous quote, of course, to bleb or not to bleb, that is the question. And we still, of course, look at the Bleb as a very important place for filtration surgery. Although many of you know me as somebody who's been quite involved with MIGS, I think that we would probably see of our glaucoma procedures, we do a fair amount, probably more than 50% of our glaucoma procedures are some form of filtering surgery. So the subconjunctival space is still a very important place to drain aqueous, although it's evolving. And one of the reasons why it is because we have no better place to drain aqueous than in the Bleb to get pressures that are low. And our patients need low pressures, but patients who are, advanced glaucoma progressing, I don't like to, dilly-dally and just watch patients and do a little minor procedure when they really need something major. No. That being said, of course, we know that there's a role for MIGS and trabecular mesh procedures for the right patient. So the theme of this talk will be, is there a better, safer, more predictable and controlled way to create and maintain a Bleb? We're all looking for this utopia, of course, and these are some of the things. And we have seen many alternatives come through the pipeline. Deep sclerectomy, non-penetrating surgery, express filtration devices, the Zen gel stent pressure flow devices have now come into vogue. Will they last or not? We'll have to see. Of course, we have our tube shunts, the valved and non-valved as well, that are very familiar to all of you. But before we get there, I wanted to first just talk a little bit about Blebs on a more science level, in terms of, how do we define Blebs? How do they work? How do we make them more predictable? How do we reduce the risks of a Bleb? How do we shorten the recovery? And how do we make them last longer? That's really what Utopia is about when it comes to Bleb. Let's first talk about Blebs and aqueous. Well, we produce about 2 microliters per minute of aqueous, plus or minus 0.5. We have to drain them somewhere. And if we're draining that aqueous, we've got to drain about 3 milliliters per day. It's not a lot, right? But it's certainly enough to keep pressure potentially elevated. And there are 3 primary mechanisms by which we think Blebs work to drain aqueous. There's a transconjunctival filtration through the conjunctiva, microcyst formation, and into the tear film. There's resorption through the venous system. We know, of course, the episcleral and conjunctival venous system. that exists around the eye. And then there's also perhaps something we don't talk about a lot, which is basically conjunctival lymphatics. And this is a nice video just from Dao Yi from Australia, just showing the injection of fluorescein in the subcon space, showing the passage through some of the episcleral and conjunctival veins. But also I want you to look at also these branching lymphatic channels that are present in a horizontal fashion, which are not classic for veins. They typically are, again, are patterns of lymphatics. So don't forget about lymphatics as being a potentially important medium. And we also see, of course, when we think about blebs in a more mature manner, typically blebs are formed from a single or two or three transscleral channels. And these basically lead into a network of fibroblasts and loosely packed collagen, capillaries and vessels as well. And although we think of a bleb infiltration after surgery, right after surgery, like this, where we have passage of aqueous around a flap, typically a more mature bleb doesn't have aqueous diffusing diffusely. It typically diffuses over a very small area, like one channel or two channels from a flap. Most of that flap you see right now will be sealed down. And only one or two channels are from it lead into the bleb. Most people don't think about it like that, but that is the reality. And if anybody has done imaging studies or has looked at a post-op bleb they have to revise, you can see that there's typically one track of fluid drainage. We see, again, fluid-filled spaces. We see bleb walls that are of variable thickness on OCT. And more we see more of a diffuse nature of these blebs. And OCT certainly has given us some more to think about when it comes to looking at bleb morphology. So when we think about it, again, the ideal bleb, we think about a bleb that has relatively normal conjunctival epithelial cells. We'd like to see more loosely packed fibrodegenerative versus fibrovascular spaces that are present. These microcysts, of course, are felt to be a positive sign. And we want to make sure that we try to, again, address any potential risk of fibrosis. And typically blebs that we see that are good have less and variable density goblet cells. And this next picture basically shows, again, birefringence imaging of filtering blebs, again, to show that when we have blebs that work well, we typically see more loosely packed collagen. We have more porous collagen. I think bleb porosity, as Michael Coote and others have talked about, I think is a better way to describe blebs. Of course, we don't have the best way to measure this, but on histopath, as you can see in imaging, we typically see less dense collagen. We see more fibrodegenerative appearance on microscopy. This is just looking at the normal monkey conjunctival lymphatics with immunochemistry staining. And again, this is something that has been well established, but doesn't necessarily get talked about a lot, is the presence of conjunctival and episcleral microcysts. And you can see the presence of lymphatics that are present here again. You can see on this video, this actually video was taken after the placement of microstents and trabecular meshwork, and you can see the episcleral veins blanch with aqueous. But also if you look at the striations, the horizontal striations on the conjunctiva with these fluid-filled, what appear to be dilated spaces, these are some of the conjunctival lymphatics if you can look closely. And this is what we feel is an important mechanism for aqueous drainage. Here we see some macrocysts that have formed again after enhancement of conventional outflow. And these macrocysts, again, are evidence of lymphatic-filled, fluid-filled spaces. This is not actually from a trabeculectomy. This is actually, again, from an ab-internal trabeculotomy. And so this is all interconnected spaces we need to think about. Well, as we know, those of us that do glaucoma surgery, a lot of this is survival, and it's about addressing wound healing. We have to be wound healing experts, and I like to always think about wound healing in these four classical scenarios of healing. Within the first 24 hours to 48 hours, we have the vascular phase of clotting and hypervascularity. We then see inflammation that typically occurs in the first 2 weeks at its greatest extent. We see the fibroblast proliferation phase, anywhere from 1 to 2 weeks to 1 month, and then we see more of the collagen remodeling phase, which occurs over the next weeks to months after the initial inflammatory phase. We must think about these phases when we address bleb survival. This is basically kind of my approach when I think about preoperative management. The best way to deal with potentially bleb issues postoperatively, like inflammation and scarring and bleeding, is to optimize the conjunctival surface preoperatively. If I had my way, I would try to stop every glaucoma medication we can before surgery, and I would put people on oral acetazolamide to control the pressure and put them on steroids for 1 month. Now, practically, that's difficult to do, but at least if the eye is red and Ala knows this, I always really reinforce this point, we should make sure we address the redness and the injection, whatever the mechanism is, whether it's the lid margin, ocular surface, the medications that folks are taking, and using steroids for me, at least for a week, is a routine phenomena that's important. Allah, I think we'll talk a little bit about post-operative management a little bit, but we know, of course, the important role of steroids. We use antifibrotics post-operatively, 5-FU, and anti-VEGF has a role perhaps early on in the vascular phase of wound healing. Of course, we have a whole litany of a progression in terms of the mechanisms of healing, and to address these, we have things that we're using now, and potentially things that are in the pipeline that may be helpful to address wound healing. We have to remember, of course, it's a steady balance. Too much, of course, anti-scarring medications can lead to potential complications. Of course, blebs contract, blebs heal, inflammation, fibrovascularity, of course, can increase this risk and concern. And of course, we also have mechanical issues as far as outflow that can all ultimately lead to fibrosis. So again, we have a lot of different options we have in our toolbox to revive blebs. Allah will speak about this, so make sure you stick around till the end of this talk. And we always like to try to enhance blebs before moving on from a pre-existing bleb. We needle in the office, we do surgical revisions, we use antimetabolites, we do all kinds of things to try to make sure blebs can, be resurrected, so to speak, that aren't necessarily functional, especially later on. So I want to again ask another question here. Is a bleb a bleb? I mean, we all know that we think of a bleb in our mind, what a bleb is, but we all know that bleb morphology can be quite variable. And we have the ideal bleb, which is that beautiful posterior, diffuse, multiple microcysts, limited vascularity, not avascular, but limited and non-cystic. We do get these with trabeculectomy blebs. We do get these with different blebs. But we want to, of course, avoid these anterior cystic, thin, localized blebs, ring of steel. These occur because of mitomycin application in the vicinity, a small zone. And also, I believe that, again, Tenon's plays an important role in this. And so I want to, again, address Tenon's capsule. We know Tenon's capsule is a very important, we think is an important part, of course, of our external environment. It's thinnest anteriorly. It's most adherent to the conjunctive sclera anteriorly. And when we look at Tenon's here in this dissection, we can see that Tenon's here is actually a separate layer from conjunctiva. It can be separated from conjunctiva. It's a fairly it's a thicker, more rough coat of the eye, and it's got, again, some certain vascularity to it. It can be separated from sclera as well, and really Tenon's acts like a sponge in many ways. When you have fluid into this space, it really expands and hydro expands, and we can take advantage of this, or we potentially could cause more problems if we don't handle Tenon's right. This video I'm just going to show, this is actually one of our fellows. First of all, you can see she wasn't in focus when she started, but this is actually more recent video, so I want to show this one. This is a teaching video for our trabeculectomy technique where we open up the conjunctiva and make a conjunctival peritomy flush with the limbus. This is typically around about 2 clock hours, about 4 or 5 millimeters. And we first disinsert Tenon's. That's the first step. Disinsert Tenon's, which is typically 1.5 millimeters back from the limbus. The tendency for surgeons is to dissect blindly into the subcon space. And I think the better approach is to find Tenon's, as you see here, grab Tenon's and to dissect underneath it. This avoids shredding of Tenon's. This avoids the phenomena of bleeding and tearing of Tenon's, and allows Tenon's to be handled as a single plane of tissue. Notice we have not injected anything in the conjunctiva, no lidocaine, no mitomycin at this point. Why? It keeps the Tenon's in a version shape to allow tissue planes to be achieved, I think, with better optimization. If I inject in the subcon space, many of you do this, they inject lidocaine and everything in subconjunctivally or into Tenon's, I should say. To me, this creates a more difficult dissection. So you can see we've applied topical lidocaine, yes. We can inject lidocaine under the conj now, under Tenon's now, but I don't want to inject it in Tenon's right away because it causes Tenon's to become hydrated and thick, and then their dissection to me is suboptimal. So here I have a clean dissection off of the sclera. Now we can inject our mitomycin C underneath. I don't think sponges are needed in most cases, and I've typically gone to injecting at this point under the Tenon's when we open Tenon's. Of course, if we don't open tissue, we need to inject, for example, when we do a Zen. But in these cases here, I already have the conjunctiva open, tenons open. Let me just inject it, into that posterior episcleral space. Keep away from the limbus. And again, I think it's very good to grab tenons. This is a more firm tissue to work with. Avoid buttonholing. We typically make our scleral flap around 3.5 millimeters. I'm just marking it for our fellow. Connect the dots is what I say here. And the goal is not to make the flap all the way into the cornea. We want to just stop basically at the end of the blue zone. We don't need to go all the way to the cornea. We want to make that filtration posteriorly. And making our flaps all the way anterior, as Pen Ka and others have talked about, risk having more anterior filtration. A nice posterior cut down is made to near full thickness sclera, and then a partial thickness flap is then designed here. And this can be done by tunneling forward with a crescent knife, as you see our fellow working like this, or it can be done under direct visualization. Many of you will cut the edge of the flap to lift the flap and dissect. The advantage of that technique, of course, is direct visualization and perhaps less likely to perforate. But the advantage of this technique is it provides a nice, smooth, continuous bed. And you'll see it when we lift the flap up shortly. But it's important at this point, when the blade reaches the blue zone here, to angle up to avoid entering the anterior chamber. This means the eye should be pulled down to avoid this phenomenon from occurring. And we want to dissect into the clear cornea to allow us to create an anterior ostomy. We I think now routinely make ostomies more anteriorly to avoid bleeding, and also potentially to avoid the need to do an iridectomy, although we do it in this case here. Now we can make our radial dissections across the sclera, and we lift the flap up. We can see a nice flap, and you can see how nice the bed has been dissected. And this is kind of what I think why the tunneling technique is a nice way to do it. I always make a paracentesis because I like to be able to access the anterior chamber. Before we do any creation of an ostomy, though, we will pre-place sutures. I'll just speed through this, and a couple of 10 nylon sutures, and then we enter the eye anteriorly through the corneal anterior dissection, and this allows, again, for us to now enter the AC. I like to typically use a Crozafon DeLong punch, or an alternative is a Kelly punch. This typically creates a single ostomy, a single punch that can be created now. And you can see by making it anteriorly, it avoids really, catching iris or catching tissue or bleeding. And by having a scleral flap that is more offset posteriorly, there's a nice punch there. You can see trabecular meshwork there. By having it offset posteriorly, we almost create like a valve effect. You can see how the flap is still attached here. It allows some protection from hypotony, although we do need sutures as well. The iridectomy can be done broadly by grabbing the peripheral iris and moving the iris to the right and to the left. This creates a more broader iridectomy rather than a narrow iridectomy. I have to say I don't do this routinely. I don't recommend doing it routinely, actually. But if the iris presents itself, and in this case, I think we felt comfortable doing it, we'll do that. The slip knot is something that is nice to be able to titrate tension. So make sure you know how to do a slip knot. And once we have a slip knot present, we can then reform the anterior chamber looking for flow. Here you can see we want the pressure to be basically in the mid-teens, in my opinion, with just a little bit of a trickle of flow. This was a bit more than we wanted to, so we can tighten the slip knot. And now we see just a nice gentle ooze with the pressurization you can see still into the mid-teens. Of course, we know suture lysis is something that we have to consider, but I want to at least have some flow when the pressure is approximately in the mid-teens. Sutures are locked and buried. And then this is an important point for me. When we close conjunctiva, this to me is really important. Rather than leaving tenons and letting it hang back, I want to bring it forward to basically allow it to basically cover the entire bleb. This avoids having an anterior cystic bleb, and it provides for a more diffuse posterior bleb. Tenons is not our enemy. I think some do a tenonectomy. I don't always do tenonectomy. However, I think if a patient is, has very thick tenons, a very young black patient, I think it is something to consider. But if you do a tenonectomy, though, I think it's important to do a very broad tenonectomy. Don't cut a small piece of tenons out. Make a broad tenonectomy. I have some videos on YouTube on this technique, and that allows for a very broad bleb over a large tenonectomy rather than making a small tenonectomy. But you can see how the tenons has been brought forward along with conjunctiva to suture together. And I think this, for me, in these patients do well. This is a more older Caucasian patient. Of course, in a younger, like I said, African descent patient, we may want to consider addressing T nodes differently. And that's kind of our standard classical approach for trabeculectomy. Now, there's been some nice modeling that's been done looking and trying to understand some of the fluidics and blood porosity and IOP control, taking into account fibrosis. And these are all mathematical modeling to predict in a modeling fashion the right optimal Bleb performance. And this is something, of course, that we're always chasing. We do want to get a posterior Bleb. We know that there are many reasons for this. The metabolic activity is less. We're away from the limbal stem cells. We're less prone to ocular surface trauma and tension, protection. We have more access to conjunctival lymphatics. There are less T-node detachments in a larger surface area, and it's probably more comfortable for patients. And I think it's a potential for a better Bleb. Penka has taught us many different ways to achieve this, including having, again, a large mitomycin treatment area, allowing for a more posterior directed flow. I think these to me are probably the most important parts, and I've mentioned some of these in our technique as well. We, of course, also have a role for tube shunts and plates, and this basically is a more resilient Bleb because we get a pseudocapsule that forms around this plate, but these capsules behave differently and form differently than a trabeculectomy. These Blebs are limited by the extent of this plate, and that basically limits the size of these Blebs. This is good and bad. That means that if we have a smaller size, we don't necessarily get as much surface area. And surface area is one of the potential differentiations between Blebs, but not the only one, of course, because Bleb porosity is more important. These plates typically cause a tissue reaction, and we have found in experiences that mitomycin doesn't seem to play a major role in the benefit as opposed to trabeculectomy. And of course, plates have specific concerns with cornea, diplopia, and erosions as well. But one interesting phenomenon is thinking about how plates developed. And this is where we see differences, for example, from a non-valved implant like a Baerveldt, where we ligate, versus a valved implant like an Ahmed valve. And we have different philosophies about why we see differences. Some of it can be because of the hydrostatic flow into the Bleb. When we have flow early on during the early wound healing phases of proliferation and remodeling, then we may get more of a thicker fibrovascular capsule. The other reason why is also because potentially aqueous, with its potentially more toxic inflammatory cytokines present, which are higher in glaucoma patients, may also lead to a more inflammatory milieu and cause a more dense, capsular lining. So for both reasons, shutting off the flow by ligating the tube creates a more fibrodegenerative, a thinner, a less thick, and a more porous Bleb around implants. And so this is one reason, for example, with Ahmed valves, we typically aqueous suppress them early after the first week to keep the flow down. And of course, we know there's many different things to differentiate one tube from the next. I won't go through all the details, but we have published some major studies in this area, looking at 5-year outcomes, comparing Ahmed and Baerveldt, and basically showing that the Baerveldt device is superior to the Ahmed. And I'm sure this can be something we can also extrapolate to other non-valve devices. We see a better success rate, but we do have a little bit more complications and more interventions with the Baerveldt than the Ahmed. Compared to trabeculectomy, for patients who've had previous surgery, tubes have a higher success rate. In this particular study, of course, well-known TVT study, but we did see a large number of complications in these eyes, a whole list of complications we need to be considerate of. And we saw that many patients, almost 50% of patients lost 2 or more lines of vision in this study, which is a substantial number of patients to lose vision after filtration surgery. We're trying to save vision, but 50% of people are losing 2 lines of vision, which is one reason we have to do better with our Blebs. On the other hand, for primary surgery, our primary tube versus trap study published recently showed that trabeculectomies have a better survival. We have to look at long-term data, but so far, even the 3-year data seems to imply that trabs are still a better option for primary surgery in low-risk patients compared to tubes. Trabeculectomy has been shown to be fairly effective in the long run. This is a retrospective study from James Kerwin. We can see, good pressure control over a long period of time and good success rate, although these cutoffs are not realistic in modern day Bleb surgery. A success rate of 21 is not really appropriate. We need to be, of course, aiming lower, less than 18, less than 15, to really judge success. That being said, we still have some complications, although these are not necessarily high in numbers. There certainly are a variety of things we need to consider about, although some of these are rare. Endophthalmitis, of course, and other issues can still occur in these cases. Probably the biggest lesson, however, is the intense post-operative management in these cases. That the success of our surgeries and trabeculectomy really relate to how aggressive we are after surgery. A lot of extra visits, a lot of interventions, a lot of maneuvers, a lot of injections, a lot of suture manipulation that has to be done. And if we're prepared to do this, we can have success. However, it has limited some of our numbers. Despite the ability for trabeculectomy to do a good job, people have been doing less trabeculectomy. And I often say, if trabeculectomy is such an amazing procedure, why are we seeing a reduction of trabeculectomy? Every other surgical procedure that has been successful, like phakic emulsification, and even RET surgery and other things, we see it going up, or at least not dropping so much. And so we have to ask ourselves, what's going on? Why do we see these challenges? And for a procedure that's developed many, many years ago, we have to perhaps think we need to move on to something we can do perhaps in a more predictable, safer, and importantly, from a patient perspective, something that may be easier to go through. What I didn't speak about earlier is, of course, some of the ocular surface issues with trabeculectomy, the refractive changes, and the long recovery. So I said before, there are many ways to create a bleb. We've seen them, some of them have come and gone, but we certainly are in the area of microshunting and microstenting. And I think we have seen in the ophthalmic world that when we go less invasive, we see a greater adoption, even though the results may be similar, with a faster recovery and less anatomical disruption and a more physiologic procedure potentially, we see that the uptake is going to be greater. But we have to, of course, perfect the procedure. I always am frustrated with trabeculectomy because although it's titratable, we're always chasing something, right? We have so many variables we have to deal with the sclera and the tension and the conjunctiva and everything else. And then we have to then decide on our post-operative management based on wound healing, which in its own way is a moving target. And so I find timing, suture, lysis, all the rest of it, I mean, it's such an art, so to speak. And art is nice, but to make predictability, we want science, we want standardization, we want to have less variability, more consistency. Like, for example, phaco. When we think about risk and benefit, we think of procedures that have higher risk and potentially have more efficacy. Usually you gain something and you lose something. You gain efficacy, you lose something on safety, right? What we want to have something ideally is we gain in efficacy, but we don't lose as much on safety. That's where we want to be in this zone here, right? To have a procedure that can replace trabeculectomy, it has to be as good or almost as good as trabeculectomy, but be much safer and create a better bleb and be more tolerable. Now, despite many people who think that trabeculectomy lowers pressure to 8 to 10 millimeters, despite those that think that trabeculectomy can get you off medications in the majority of cases, the literature actually shows this is not true. The average pressure in patients with trabeculectomy in prospective studies and retrospective studies is generally around 13, 14 millimeters of mercury. That may surprise you because many times I hear, I need a pressure of 8 to 10. I'm going to do trabeculectomy, which I think is our best procedure to do that. But on average, we don't get there. We can titrate to get there, but we have to be realistic that we don't always get there. And so when we look at these success rates, for example, I would say looking at less than equal to 17 on no glaucoma medication is a reasonable measure of success. Our success rate ranges anywhere from 40% to 70%, right? So that is not a very high success rate. So I want you to remember these numbers when we think about comparing to newer procedures. But again, it's not just about IOP, like I said. I mean, truly we need to move forward from a patient perspective to think about things like, for example, visual recovery, visual acuity, refractive impact, the postoperative intensity, intervention, bleb morphology, comfort, infection risk, and consistency. After all, our goal is not just to lower pressure, it's to enhance the quality of life for a patient in the short and long term. This is why we have tried to move toward novel devices like the Zen and the PreserFlow InFocus MicroShunt. These are ways that we are trying to standardize bleb procedures and make it perhaps make a more amenable bleb. And both these procedures rely on basic Newtonian physics to control flow based on lumen resistance, to prevent hypotony in the early postoperative phase, and to create a more consistently draining bleb. However, one thing we've realized that the physics of outflow in the early postoperative period is different when we compare a single lumen outflow versus a trabeculectomy outflow. And I won't go into too much detail, but this likely relates to early Bleb morphology. We need to consider this in terms of the physics of how fluid drains from these systems. We also need to think about tenons again, back to tenons again. With a trabeculectomy, we cut tenons away. Whether you leave it alone, I am guessing that most of you, like I've seen my colleagues, typically leave tenons and ignore it. And in trabeculectomy, you can get away with it. But in a stent like microstenting, if we leave tenons and not think about it, tenons can scar down, can block the implant, so to speak, and cause contraction. And so we need to consider these things and these issues. The Zen gel stent, of course, is a flexible gel stent. We've seen the data on this. It creates resistance to prevent hypotony, assuming a normal physiologic outflow rate. And in many cases, we typically see a nice diffuse posterior bleb. However, our biggest challenge with Zen has been a higher needling rate and challenges with fibrosis. And we think this occurs for a couple of reasons. One is the issues around the implant being stuck in tenons and higher resistance. And the other may be to lumen blockage for different reasons, including airlock early on. And one way we like to address this early on the table is to look at the position of the Zen gel stent. Both of these implants appear to be mobile, but the one on the right is much more mobile and free than the one on the left. The rebound test shows that the one on the left is still caught in tenons. And so in a trabeculectomy, we don't have to worry about this, but when we do an ab internal microstent like this, we need to consider this. And so when we do the procedure here, just to show quickly the procedure here, we essentially, I have now moved away, like I said, from injecting mitomycin C or lidocaine in the conjunctiva. I like to work with virgin tissue when we're passing the needle. This needle, this is the Zen is inside this 27 gauge needle. You can see it right there. And the needle is passed ab interno into the angle right above the TM and emerges in the episteral space, 2 millimeters from the limbus, and we want to basically really get through tenons. How do we know we're through tenons? It requires us to lift our tip up and put our hand down with our injector through the eye and almost poke the conjunctiva. High magnification reveals a very visible needle with the implant being emerging here, and you can see how thin the conjunctiva is over the implant. This is what we want to see. We don't want to see a thick tissue over it, because if we see that, we're likely stuck in tenons or deep in tenons, which in my opinion, I think is not ideal. And there we can see the implant nicely placed. We can see the implant in the anterior chamber, which is what we want to see. And we want to make sure we test for mobility, like I said earlier. In another case, we can show the implant. At the very end of the case, I typically will use the 30 gauge needle to inject mitomycin. We still need mitomycin. And we'll also make sure the implant is free by swiping the needle around the implant. This is something I do now routinely. I think it just helps us to make sure the implant is free. And I'm already in there to do the mitomycin injection anyways. And so this allows us to free the implant. The mitomycin is injected, and I think many people are very scared about mitomycin injections. I can tell you nothing to be scared about. Mitomycin will not enter the eye directly. It goes into the subcon space where the resistance is lower, and it's not going to go through the little implant. Furthermore, we have viscoelastic in the anterior chamber as well, which also can prevent this from occurring. After the mitomycin is delivered in the space, we inject about 0.1 cc, nicely positioned in the implant, distal end of the implant. It'll lead to a nice diffuse bleb there. We can then clear out the viscoelastic, and we have a nice bleb that's formed. In this case here, we're showing an open revision of a case or an open procedure. There's a Zen implantation. And one thing that I want to just mention is that we also use Ologen. Ologen is a powerful tool, in my opinion, to help with remodeling of conjunctival fibrosis. It also helps to create space. And we are using this in revisions and also high-risk procedures, trabeculectomy, Zen, PreserFlow. I think it can be used in all those situations. And I think it creates a nice scaffold for healing. I have been pleasantly surprised and happy with those results. Some studies have shown the benefit here. And what I'm doing here is I'm putting mitomycin C into the Ologen, which is a 6 by 2 millimeter disc of collagen matrix and glycosaminoglycans. And this may enhance the delivery of mitomycin, but also creates a very nice diffuse bleb that we can use in higher risk cases like this, where we did a Zen revision here. So I do think that there's some values that I think we see with the Zen gel stent. We see, I think, reduced severe complications. We have less invasiveness, shorter recovery, and we have less impact on the patient recovery with vision and a faster visual recovery. It's more versatile as well. I won't go through all our studies here, but I think we have some good publications that I think do show the benefit and the differences between both of these implants and trabeculectomy. We do, however, see higher needling rates, and that's something that we're trying to address with novel techniques, as I showed earlier. And we're still kind of chasing the optimal positioning of Zen implantation, although I think it still has an important role. And the beauty of it, of course, is how the recovery is smoother and how the invasiveness is less. The pressure flow implant is another implant. This is probably our most potent implant. This is made of a material called SIBS, which is a tri-block polystyrene compound. This has been shown to be very, very stable and very biocompatible and with less inflammation around the implant. This is because of the stability of the material to oxidative stress and breakdown, and it's superior to silicone or polyurethane, which has been typically used in the human body. So I think it's a very good material, which has been used, of course, as well in the coronary stent world. And we've seen good data to show reduction of fibroblast deposition and myofibroblast cellular, thickening that can occur with a silicone versus using SIBS material. Again, also having a resistance that's titrated to allow hypotony protection. And this video will just show the technique. I like to do, again, a peritomy that's flush with the limbus. And I really don't mind, making a nice larger dissection. This is about 3 o'clock hours in opening, but it allows me to have a good visualization. Notice how we are releasing Tenon's capsule. Again, this is similar to my trabeculectomy opening, a bit larger, but we're really carefully dissecting Tenon's, carefully dissecting it off the sclera, and without traumatizing it. It's important to do this in one tissue plane. And we can now see we're grabbing Tenon's. Tenon's is still attached. Look at Tenon's, how it's attached to the sclera still. See, we need to create a deep pocket where we want aqueous to drain. We want the implant to go posteriorly. We want to be careful dissecting around the muscles. We want to just cut up to the muscles, and then we can swipe left and right. I call this the Tinder moment of glaucoma surgery, where we swipe the scissors back and forth. And here's my mitomycin delivery. We still use sponges sometimes, and certainly for InFocus, we're still using it, pressure flow. And we're also injecting mitomycin C as well. So we give them a very big dose. And one of the things I think we have found with these procedures is the benefit of using a safer approach. We can use more mitomycin. We then make a 3 millimeter tunnel back from the limbus, and then the pressure flow implant is placed here. You can see that the little middle positioning of the fin allows it to secure itself to prevent movement, and it also blocks any flow from around the tube. We see nice flow emerging from the implant there. And then we then close Tenon's, and just briefly I want to mention, look how carefully we're closing Tenon's over the implant. This is important so we don't catch the implant in Tenon. Look at the implant get caught in Tenon's there. This is why we need a good dissection. This is not a good position for the implant right now. Release it from Tenon's like you see there, and then close Tenon's on top of it. I think this is very important to ensure that we avoid entrapment of the implant. And these blebs have been really the best looking blebs that I've really ever seen with glaucoma surgery. Beautiful blebs, diffusely present, rarely avascular, with good pressure control. As you can see, inferior blebs also, and even contactless compatible as well. And I won't go through all the data.
Like if I can go in a very quick question. One of the audience was wondering about when you inject the Ologen with mitomycin C, aren't you worried about local necrosis?
No. And one reason I think is because we basically are placing it over a diffuse area. This is basically like placing a sponge. Remember, when you place a sponge with mitomycin C, the absorption of mitomycin C occurs fairly quickly. It occurs within about 90 seconds or so. So even injecting mitomycin C, people say, do you get necrosis when you inject mitomycin C in tissue? And we don't see this. Of course, mitomycin C can cause necrosis. It can cause thinning and avascularity. But in our experience, it's no different than with sponges. Because even with sponges, once you have the sponge in there for 2 minutes, the mitomycin basically has been resorbed into the tissue. And it's the same thing when you inject or when you put it on the Ologen. It gets absorbed pretty quickly. So we just don't see it. But it's obviously a very good question, and I realize the fear of mitomycin with using it in these manners. But all I can tell you is just thinking about the physiology of mitomycin and thinking about our clinical experience. That's what it's been like. The other thing with mitomycin C is I think that it's important for me at least is to put it under tenons, and by closing tenons, I think that also this protects us from conjunctival thinning and melting and necrosis as mentioned. And so I think it's very rare. Of course, it has been reported, not with injection, not with Ologen, but it's reported with sponges. So it can occur, but I don't think it's an increased risk in these cases. Just to wrap up here, I think we've seen these implants, pressure flow implants and Zen implants, I think create a more a safer bleb, a faster recovery. And actually, this has allowed us to even increase the mitomycin delivery because we have a procedure that is very protective against hypotony and with a very diffuse posterior bleb that I think we have more luxury of using more mitomycin because no matter how great a procedure is, we're always dealing with issues around long-term fibrosis, which is always going to be an issue. So going back to the beginning of my talk, these are some of the things that we need to define a modern day bleb as we talk about Bleb Utopia. I think we're getting there with these newer devices. If we look at this example in the first 2 months after surgery, trabeculectomy, Zen, and InFocus. On average, the pressures are written below in the first 2 months, right? It's actually lowest in InFocus in the first 2 months. Almost 200 patients in each group. And look at the variability in IOP. It's all over the place in trabeculectomy. With Zen and InFocus, it's much, much less. InFocus particularly. Look at these 200 patients. Only 3 or 4 are up and down. The rest are all consistently. You can almost predict with 95% accuracy that everybody's going to be in the low teens for the first 2 months with very little variability. Look at the difference in trabeculectomy. It's all over the place. And what does this result in? I think it's less snuff out. I think it's faster visual recovery, and it's more total visual recovery for our patients. So I hope I've been able to share with you some of the pros I think are important for Bleb Utopia. I do believe that we have better alternatives. We still aren't 100% there yet. We still have complications. We still have problems. One thing I didn't speak about is when you have a single lumen, if you have blood or pigment, it can block that lumen, more likely to occur than with trabeculectomy, which can even happen late postoperatively. This is something that we still have to grapple with as well. I've shared lots of videos, of course, and I love, of course, having people visit, and always welcome to keep in touch on social media. So thank you for the opportunity to be here. I will let Allah speak a little bit. I think Allah, you've answered some questions as well. I see a lot of people have asked some questions. As maybe we transition to you, Allah, I can answer some of those. I can say in our practices, Allah will say, we don't do trabeculectomy a lot. We find that between pressure flow and Zen, this takes care of most of our patients. But I do agree, someone who needs a pressure of 8, we have a higher probability at least of getting there with early suture lysis with trabeculectomy. So I think that would be an indication for trabeculectomy. Otherwise, it's something that we find is not as common as we do with other implants. So Allah, I think you've answered lots of questions, which is great. Thank you. It looks like you've taken care of all of it, which is very good. Thank you.
Yeah, there might be one or two questions at the end. So I think there's one question about how to handle a thin tenon patient.
So yes, tenons is thicker in young patients and patients of darker pigmentation. Older patients can actually have, you find tenons is retracted. So tenons is actually retracted into the fornix. So one can actually open the conjunctiva and find tenons and actually bring it back forward again. If you actually dissect posteriorly, you can bring it in and bring the tenons forward. That being said, for older patients who have thin or no tenons, I reduce the mitomycin dosing. I think it's important to dilute it, go down to 0.2, for example, or in my opinion, for very old patients, do an Ahmed valve. I think there's more safety in this, and our patients don't need a pressure of 10 at that age group. And the blebs, I think, are less prone to breakdown when you do it this way. So that's kind of what I've done for my very old patients with very thin tenons. Okay, Allah, should I introduce you? Allah Mufti, you've already heard about. You know him from Saudi. He's spent 3 years. He's a very dedicated ophthalmologist, I'll tell you, very dedicated. and really is so keen on helping patients and helping people. I think he's going to be a big force and someone to work with in Saudi. So please welcome him back when he goes back to Saudi, if we let him back here from Canada. And I appreciate the hard work he's done. He's been working so hard during the COVID time to take care of our patients as well. So thank you, Ala, and we look forward to your presentation here today.
Thank you so much, Ike. I mean, your talk was really inspiring. Working with you and seeing your experiences with subconjunctival surgeries and MIGS is really phenomenal. And it's really a pleasure for me to present today within my first home, KCASH. I'll do my talk, and I'm sure it's not as utopic as Ike's talk, but as a fellow, from a fellow's perspective, I would show you some tips and tricks, things that I think that are essential with your glaucoma management to enhance your success. I don't have any financial interest to disclose. And in my lecture, I'm gonna discuss some factors that affects the bleb healing, some measures that we take during pre-operative, intraoperative, post-operative periods to enhance surgical success, and procedures that can enhance the outflow. So basically, Ike have mentioned a huge part about how blebs kind of form. So there are stages for bleb fibrosis. It starts off with an inflammatory phase. So you have a collagen layer where when we do a glaucoma filtering procedure and you have fluids going into the subconjunctival space and subtenon space, then you have a conduit. You have extravasation of blood that happens through the blood vessels, and then formation of fibrin clot. With time, you get recruitment of inflammatory cells in that area, and this is when you get release of the growth factors and inflammatory cytokines. You reach a stage where then you go to the proliferative or repair phase, where the fibroblasts start to lay out layers of extracellular matrix, and this is where you get the collagen layer get thicker. You get some vascular tufts that form granular tissue, and then you have more cytokines that then kind of decide which way your bleb goes to. So after months and years of surgery, you go to the remodeling phase, and this is when the collagen layer starts to contract, and this is when you get the fibrodegenerative scarring. And it's based on whether or not you have a balance of pro-inflammatory agents and how much anti-metabolite and anti-inflammatory agents have been introduced to the bleb. You could end up with a perfectly well-diffused bleb with good thickness. If you have an abundance of pro-inflammatory agents, more than I would say the anti-metabolites, then you end up with an encapsulated, thick, scarred bleb, as you can see over here. And if you're in a situation where a patient does not have a lot of pro-inflammatory cytokines and more of a mitomycin, localized mitomycin application, I would say, you get those thin-walled, porous, leaky blebs. So this is very important to understand, because you realize right now that your number one enemy over here is fibroblasts, and this is what controls the future of your bleb, and this is very important. You have to realize that certain conditions has a tendency to increase the risk of bleb failure. So someone who is young, they have aggressive healing response with thick tenons. Some racial phenomena have been introduced, have been associated with bleb encapsulation. Dark skin or black people, for example, have more fibroblasts and macrophages in their conch. They have keloid formation tendency, and they have Asians, for example, have more complication rates with antimetabolites. Someone with neovascularization, cases with neovascular glaucoma, for example, they have abundance of transforming growth factors that gets released, and therefore increasing the amount of scarring that can happen. They have broken blood aqueous barrier as well. And when you operate on them, they get intraoperative bleeding and therefore more healing response, and fibrovascular proliferation happens aggressively. Someone with uveitis shares the same thing. Chronic breakage of blood aqueous barrier and subclinical inflammation will lead to more cellular activation, and this is why you get more scarring. And someone who has had previous surgeries in the past, they've already had a layout of conjunctival fibroblasts and inflammatory cells there. So, so it's very likely that when you go and operate again, it's going to be, there is a tendency for scarring. Histopathologically, some studies have looked into eyes. When you look at an eye treated surgically with and without mitomycin, there is a major difference in histopathology. An eye that is treated without mitomycin has more fibroblasts, contractile proteins, parallel-oriented collagen fibers, and more ground substance. Whereas when you apply the mitomycin C, you get reduction in the amount of contractile protein and fibroblasts and ground substance, and the collagen fibers are randomly arranged and therefore should not impede flow. Now, you would think, how would we reduce our chances for scarring? We'd start with pre-operative measures. The first important thing, as Ike have mentioned, is optimizing the conjunctiva. It is very important. We don't realize that most of our glaucoma drops can actually affect the health of the future bleb or the conjunctiva. And this is because the benzalkonium preservative can actually alter the surface. It can lead to deposits of more fibroblasts with time. There have been studies that have looked into using alpha agonists and prostaglandins, and they found that it increases the number of fibroblast lymphocytes and macrophages with time. So one thing that, as Ike mentioned, we usually do is that we actually bring the patient on a pre-op appointment. We actually stop one or two agents, mainly the alpha agonists and the prostaglandins, and we shift them on Diamox. And you might think, okay, but the pressure would rise up. But what you're actually concerned about is the conj health. What is really important before surgery is to get that conj quiet and ready so that to increase the surgical success. I wouldn't be worried on a short term on how the pressure control is, providing that you're planning your surgery, let's say a month ahead or something, not longer than that. Topical steroid use is very important. I'll mention that in a different slide, but we start them as early as 1 week before surgery with 4 times a day steroid. And during the day of surgery, before operating, applying phenylephrine 2.5% on the conjunctiva help do vascular constriction and reduces the risk of operative bleeding, and therefore you get better results. Now, intraoperatively, and I think this is very important, I have shown greatly how conjunctival dissection technique can really matter. I would say the first point that you have to do is never blind dissect your conjunctiva. Make it a habit to always separate it in different layers. One thing I've learned from Mike, if you notice, as soon as he opened the parotomy, he had like a small ooze of bleeding and he immediately went into cautery. He always told me that like bleeding is your enemy over here. So he always aims for a really white sclera, non-bleeding sclera. And you can see over here, he's doing snips. He's not passing the blade bluntly, and like he's doing snips because it does control cutting. You avoid disinserting tenons unnecessarily. And now he was able to identify a streak of tenons, and he made a break or opening, and therefore he's able to carry a clean dissection and separating the tenon from its insertion cleanly. So you don't have any loose tenons over here. And I'll just speed up the video over here. So you can see we've cauterized extensively. And in the end, this is what you want. You want like a separated layer of tenons and conj, very white sclera. And I'll show you in the next clip. And this is how we get tenons. So you use microforce, like you can get your tires and just pull out the tenon from the behind. And you can see how it pulls like a very uniform thick layer. And you grab this and you keep holding it firmly. And then you can go with your procedure as necessary. You can cauterize more. And you can see over here, let me just do that again. So he will start dissecting at a certain stage. I think we might have passed this, but oh yeah. So this is the swipe left, swipe right. Must have skipped it. Sorry about that. Yeah. So maybe I didn't put the proper clip, but then we actually introduced the West cuts over here with like left and right, and we release the tenon. This is where we pull it, and then we put our mitomycin sponges. It is very important to understand the mechanism of how mitomycin and 5-FU work. So mitomycin is an alkylating agent isolated from streptomycin, and 5-fluorouracil is a fluorinated pyrimidine analog. They act differently, as mitomycin binds to all phases of cell cycle, whereas the 5-fluorouracil binds to the S phase of the cell cycle, but they all work in a similar way. They kind of cross-bind with DNA, and you get inhibition of fibroblast, endothelial growth factor, and protein synthesis. And mitomycin, when it binds there, it kind of prevents fibroblasts from growing and working. And this is very important because one important aspect is that when people were concerned about like conjunctival thinning with mitomycin, Ike have shared a very wonderful experience with us about how people used to apply mitomycin in a localized area, and this explains why in the past we've seen trabeculectomies with very thin conj apex. Whereas now what we're doing is, if you do the proper dissection technique, as Ike was doing, you have very posterior working space to place your mitomycin for. So if you spread it on a very diffuse area, you don't get an ischemic bleb over time. And this have helped, Ike pours a lot of mitomycin, more than any surgeon I've worked with. He does sponges, he does the additional injections, we call them mitomycin C+. And if we're using collagen, this is also gets an injection of mitomycin. And we don't see bleb thinning. So this is very important. Corticosteroid post-operatively is very important, and it's very important that we do it in high frequency. Steroids inhibit inflammation by leukocyte suppression and impairing the macrophages function. So you get less vascular leak and less clotting factors, and therefore less fibrin. There have been studies that looked into, when you pre-treat someone with steroids, as I've previously mentioned, you tend to have lesser fibroblasts and lesser inflammatory cells in the conjunctival specimen compared with someone who is operated for TRAP without pre-treatment. So pre-treatment is very important. And post-operatively, I would recommend going for high frequency, long duration use. For us, we keep patients on steroids for 2 to 3 months. They start off the first week with every 2-hour regimen. Then we shift to 4 times a day for 6 weeks. And then we taper. And even when we taper them every 2 weeks. So 3 times, 2 times, 1 time, 2 weeks apart. Another important factor is to grade your bleb. So the reason for that is I know how people uniformly talk about blebs in general terms like diffuse, low, flat. If you have a grading system where you can systemically grade your bleb, and therefore you would be able to decide if an intervention is required or not, this is much better. This is called the Indiana Bleb Appearance Grading Scale. It's based on standardized photographic images where you can grade the bleb height, extension and width, vascularity, and in cases of leak, you can grade the Seidel as well. Most importantly, I would say for vascularity, for example, if someone is graded as moderate or severe vascularity, which is like V3 or V4, this is an indication for us to go for an additional anti-metabolite supplement, which could be like 5-fluorouracil injection. And we do that often in clinic when we feel that the bleb is highly vascularized. This is a modified or our own bleb grading system we developed in Mississauga. And basically what makes this distinguished is that it's more directed toward mixed procedures because it also assesses microcysts. And you see, it's kind of the same thing. So when we talk in clinic, when we communicate through channels describing a patient, we go in codes. So like V1, A3, P6, for example. So I can know that this person has low vascularity or mild vascularity and on an area extending 3 clock hours, 6 millimeters like posterior flow, It's elevated 1 corneal thickness, and there are like moderate abundant microcysts without leak, 0. I really encourage that you tend to grade your blebs so that you manage them well. Now, it is very empirical as well to learn how to do post-operative in-office procedure. And I say in-office because I know in some practices, I would say, in the Middle East, we usually take patients for bleb needling in the OR environment. I do really believe that making it a minor OR room or a slit lamp procedure as well is effective, because you address the issue of bleb encapsulation if necessary on the spot. You also save OR slots for patients who are in need for major surgeries. And basically, to do it on a slit lamp, you just need to numb the eye with tetracaine or lidocaine jelly, and you can repeat it several times until the patient is comfortable. When you put them on the slit lamp, you could start off with injecting mitomycin C with a 30 gauge needle on a 0.1 cc syringe. You inject 0.1 volume, and you do that 20 minutes before you plan to go for your needling procedure. And then afterwards, you use a 27 gauge needle on 1 cc syringe. And the aim, if you're doing it for a trap, you just want to go under that flap and lift up the flap. And the second goal is to go through the ostomy into the anterior chamber and reform this connection again. If you're doing it for a device like the pressor flow, or you're doing it for the Zen, the aim is to go in and lyse the tenons adhesions that might be stuck at the end portion. So you try to go under and over the implant and swipe as far as you can. I'll show you a video. Just hold on. Yep. So this is a video of how we do needling. This is a Zen case, by the way. So you can see over here that we're using a Q-tip to elevate the eyelids. You could use a speculum, but I noticed that speculums usually kind of drop down to your view, and it's kind of impractical. Using a Q-tip would be more sufficient. We went in with the 27 gauge needle, and we're pushing the needle. We started 3 clock hours before where the Zen is placed, and we're trying to reach where the Zen is. I'm going to speed up for time. And okay, and you might notice there's a yellow hue over here, which is the tip of the Zen. And you see how we went below the Zen implant, and we're swiping as posterior as possible. And with multiple needling swipes, you can start to see how the bleb start to forms. And we keep doing that until we get a very nice diffuse bleb. So we went under, then the next step we go above. And we do that by having the needle go as close as possible to the conjunctiva. Like we go subconjunctival until we see our needle. And we can use the Q-tip as well to assess the IOP as well, and know that we're going into the right direction and having the optimum pressure. Now, I'll show you another video of another procedure that is important with subconjunctival MIGS, and I have my last slide and we will conclude. So basically, sometimes if we have a scenario of a internal tube obstruction, we can do this in the minor OR. This is a 23 gauge thin-walled cannula that we use to flush or irrigate the microstent or microshunt. We just go through a 1 millimeter incision or a 1.5 millimeter incision. We fill the eye with viscoelastic. We were able to cannulate the microstent, and we just injected, and you would see some bleb forming in a while. And this is very useful when you have cases where you suspect that an internal obstruction could be a thing. They present usually with an, like they start off with a normal postoperative single-digit pressure, and then all of a sudden you get the patient coming with a spike of pressure in the 30s, and this is where you should suspect that internal obstruction with these smaller lumen devices as possible. So this is one procedure that is very critical to learn also to do in office. And I'll just go into Bleb revisions, which is sometimes necessary to go for in terms of if needling procedure does not work. Now I'm showing a Bleb leak case obviously over here, but it's kind of the same concept. I wanted to show the principles where you can see over here that even though we're dissecting posterior to the ischemic Bleb, we're still respecting the rules that we've defined, in which we dissect the tenons carefully and distinctively from the conjunctiva. We never leave chunks of tenons attached. And this is a good example where we had some contraction and the conj does not extend beyond the area that we want. So we did some snips into the conjunctiva to allow the conjunctiva to relax. And afterwards, you will start to see how the tissue, we're able to advance the conjunctiva even more to the limbus. So this is a very good trick in case you had some contraction and fibrosis. I mean, in this part, we excise the ischemic Bleb. I'm sure everyone is familiar with that. This is a good case where we kind of utilized tenons as a patch graft, and we used it to cover this area. Other times, you can consider doing a full extensive tenectomy, as Ike have mentioned, especially in cases of revision. We do that a lot. So, special mentioning for subconjunctival MIGS, sometimes we reassess the stent length and position. Sometimes they're shortened inadvertently when doing needlings. So sometimes we can exchange it on the spot with a newer implant. Another thing to consider is to add Ologen. So Ologen is a flexible biodegradable collagen matrix. We place it on top of the microstents to act as a spacer, and it helps regulate the formation of fibroblasts, and it prevents the cell migration through the porous formation. So you don't get a fibroblast or scar tissue formation on the Zen. The Ologen would be like a continuous barrier between the Ologen and the subconjunctiva. And that's it for my talk. I would like to thank everyone for attending.
Thank you, everybody.
Thank you. Thank you very much. I thought those were excellent talks and very complimentary indeed. And the nice thing I thought was that you went right back to basics and started talking about, Bleb morphology and wound healing and remodeling. And these are concepts that, I was grown up with as a resident and carrying 5 FU syringes in my pocket to inject post-trab. Mm-hmm. So I think now the residents and trainees have, they don't tend to think about that so much, how we can modulate wound healing. So I thought that was really, really useful. And thank you for...
Yeah, I think to be a glaucoma surgeon, you have to have a degree in fluidics and a degree in wound healing. I think those are 2 essential, components of a successful Bleb surgeon, a blebologist.
And thank you for answering most of the questions that we've gone along. Conrad, Dr. Wader, did you have any comments?
No, excellent talk. As usually, the talks that Ike made, very, very good, excellent. Basis of the Bleb, our big dilemma always trying to save that surgery or going for another one. So I think that we have to use always the last resource in trying to save that one. Perfectly clear, Ike, as always. Great to have you here.
Oh, thank you. It's so nice to be with such nice friends. I mean, you're so kind. Thank you. Appreciate the invitation.
Thank you so much, Dr. Ike. That was very excellent presentation, and thank you, Allah, as well. And I'm glad to see you again. Actually, we have so many questions, but we have a limited time. Unfortunately, we have another oculoplasty webinar just following. So I wish we can have you again with us. It was so honoring, glad to have you here.
Inshallah, anytime.
Inshallah. Do we still have more time, Dr. Rezwan?
I think we have about 5 minutes. Yeah, just 1 or 2 questions maybe.
Oh, the oculoplastic people are going to be mad.
They might learn something, right?
Yes.
maybe I can drop a quick question. If you can share your experiences about using pure mitomycin injection instead of mixing it up with lidocaine. I know a lot of people mix it with lidocaine. They worry about the concentration.
Yeah.
So and I know you have
we
like
don't
an interesting
with lidocaine. I mean, it's not a problem necessarily. We did do a study actually looking at potency, whether the potency of mitomycin is reduced by the pH of the lidocaine. And it doesn't change the potency. In fact, lidocaine is cytotoxic as well. But I just find I don't need to. I think it does dilute the concentration, of course. And if you inject too much volume, you expose too much tissue with it. So, yeah, I have not. Maybe our patients in Canada are different than other places, but I don't find I need to use lidocaine subconjunctivally. Put lots of topical on, lidocaine gel if you need to, and that is typically sufficient for our procedures, whether it's at the slit lamp for needling or whether it's in the operating room. It's been, I mean, although you know that's what we do, right? I mean, it's maybe surprises people, but I think sometimes we think we need it, we don't need it. So that's from my opinion. I just don't like to do more than I have to for those cases.
So patients don't complain of stinging, Ike, with post-op?
So I mean, post-op they might. I mean, but even if you inject lidocaine, I mean, that's gonna last just for a short time, anyways. I think So, but yeah, I mean, I give them lidocaine. I mean, I give them topical drops. I think the absorption of topical drops in the conjunctiva is quite good. It's when you start to manipulate muscles and things like that, which gets more uncomfortable. And so, for example, for tube shunts, we open up the conj and we do a subtenons, a posterior injection for that purpose. So I find actually that no, patients are comfortable. They do sometimes complain, of course, of foreign body sensation. We bury our sutures for that reason. We protect the cornea so we don't get epithelial defects. But yeah, no, I think I've been, like I said in my chat, I don't typically patch the eye either after surgery. We shut the drops right away. I want the drops to get started to get their effect. So, but I agree. I mean, I think that different communities have different demographics and different perceptions of pain and discomfort. So to be fair, it'll depend on your community, I think.
Great.
What's the most common procedure done at KCASH for glaucoma?
We do a lot of tubes. And part of the reason is that, most of the patients come to us have a failed trab already. So from that perspective, when you guys are talking about the in-focus, potentially that could be a very useful procedure in our population.
Mm-hmm.
It's been interesting. I mean, I did a lot of tubes before, but in-focus has replaced a lot of our tubes actually. It has a benefit of a tube, but a trab-like performance in IOP, and yeah, I look forward to how you all will use it. I think it's been all I know is it's been one of our most popular procedures. We use it in everything.
Yeah.
And it's not the panacea. It doesn't solve everything, and we still have failures. And I think Allah, right, the thing we grapple with, we have a patient tomorrow coming in that is doing great for like 8 months, and then boom, the pressure is 50, right? And this goes to show that these patients can get lumen blockage, right? Which we don't see in trabs. I mean, how many trabs do you see where they're doing great, all of a sudden the trab goes to 50? It doesn't happen. But with these small lumen devices, though, this is what perplexes me. Mm-hmm. And they have, fibrin, or they have some deposition of protein or pigment, whatever it is. And I think these lumen can get blocked. So we have to still grapple with that. Now, it's not the most common. I mean, we have done 1,200 more cases of in-focus, and maybe it's only a handful of cases that I can think of. Maybe 15 cases I can think of, 20 cases maybe maximum. So it still happens, but otherwise I have to say it's been great. It's been an amazing experience to do in focus in the post-op. Do you think Allah can go to sleep?
I still remember a case like I was really impressed with, like someone who had a supratemporal and supranasal tube, and usually people like this, like they scar really well. And I remember we've implanted the nasal in focus with him, and he's doing fine. And I've never thought that this could be like something to do after a tube. So.
And is it an Ahmed valve or Bearvolt or different design tube you're using? In Saudi. What do you guys do?
We do a lot of Ahmeds, and I think that was the traditional teaching here. Having trained in the UK, I started doing Bearvolts, but now we switched to doing Addies for younger people and children. They get less encapsulated, and we noticed that
I think so.
compared to long-term
I totally agree.
results.
I think it's Rezwan who's doing more tubes, but we still do more of deep sclerectomy here as well, especially for the congenital glaucoma. Yeah, but Rezwan likes to do more of tubes.
Yeah, I used to do lots of deep sclerectomy, a lot. Used to be my favorite procedure, but since I have Zen and PreserFlow, I just moved to that, and I think it's been just a more simpler approach. But
and what's your experience of ab externo Zen implantation, Dr. Ike? Because we are not so much encouraged with the rate of post-operative needling for Zen. So does it make a difference if you shift to ab externo?
So ab externo can mean different things. I mean, if it's transconjunctival, going through the conjunctiva, I think that people do find maybe some lower rates, but I think there's other issues as far as the placement in the anterior chamber and the amount that's left in the subconj space. So I have not really moved over to transconj, but open conjunctiva. We used to do lots of open conjunctival procedures, like I showed with PreserFlow. And with open conjunctiva, I think you have the least needling because you have everything exposed, you have everything visualized, and you can close tenons without worrying about it. So some of my colleagues, you have Randy Craven used to be with you guys, other people, Joe Panarelli. A lot of people have moved toward I call it open conjunctiva. There's open Zen, there's transconj external Zen, and then there's ab internal. And I still do ab internal. I want to still try to perfect this. I think we're getting better, but we still have some challenges. Open conjunctiva, and then transconj is still, in my opinion, I don't quite feel comfortable yet that that's going to be the answer. But people have different opinions on this one.
Yeah.
But I do agree. The single biggest challenge for Zen has been needling, and we have to address that by placement of the needle and other techniques that I've described and other people have described as well.
Great. Thank you very much.
Anything from Conrad? Conrad, you always have some wise thoughts.
Well, no, I'm just paying attention to what you are saying because, I use the Shen and talking about the Shen, one of the things that I didn't like much and what it happens in Europe now is that at the beginning, we were talking about different techniques of implantation of the Shen.
Yeah.
But the last time I went there for the Spanish meeting, we were talking about the complications of or handling of the Shen after following 3 to 4 years. So I think that the InFocus probably has the advantage of, as you say, full exposure and proper manage of the tenon and the conjunctiva. So I think that we start looking, but absolutely right, is an option and it's a very good option too.
Yeah, so, I think this is still in development. I mean, it took a long time for trabeculectomy to be where it's at, and same thing for tubes. I mean, tubes have been around. Remember, Rezwan, I mean, Bearvelt's Ahmed's Molteno has been around for 30 years, right? But only in the last few years, we're seeing people use it more, right? Studies have helped us. So yeah, this is a long journey here. Bottom line, long journey. We have a long way to go.
Yeah. Yes.
Great. As you said, the challenge is having a nice looking diffuse bleb with good pressure and also considering patient outcomes in terms of visual acuity and post-operative recovery.
Absolutely.
And what I said, that you can go home and sleep well.
Well, that's definitely true for some of these microstents. I mean, we don't typically see disasters or challenges in bringing people back every few days, although it happens sometimes. And then the other thing I think we have to also not forget is that these patients need long-term management, right? I mean,
absolutely.
I almost wish we could have, a continuous wound healing modulator. And I mean, Allah knows we've been talking about, should these patients be getting, mitomycin every 6 months or getting some injection every 6 months to control their issues around healing, because that's going to still be the challenge long-term.
Yeah.
And so we do need to think about something to be able to give the patients long-term to address the wound healing.
In one way, that was what it moved me to the deep sclerectomy. And once I arrived here to Saudi Arabia and I see how they manage here the deep sclerectomy, I become even more a fan of the deep sclerectomy. That's the thing.
Yes, it's very nice. I mean, if I had a choice between trabeculectomy and deep hysterectomy, I would do deep hysterectomy, and I did a lot of them. But I guess we've had enough success with Zen and PreserFlow that the advantage of deep hysterectomy then becomes less, comparatively speaking. I mean, deep hysterectomy, for example, we have about a 60% goniopuncture, right?
Yes.
And we still have anterior flow, right? So there's still some nuances that you cannot avoid with deep hysterectomy, which is okay. Still, I think it's a safer option. But to put a stent in and just put it in and let it go, if it can be successful, is really for me like the ultimate.
Yeah.
So we'll see.
We'll see.
Great. Thank you all again. Thank you very much, Ike. Thank you, Ala. Really great talk and very good complementary information. And we look forward to having that implant with us and getting to better patient outcomes.
All the best. Keep on striving. Keep on education.
Thank you.
Keep well. Always good to see you guys. Take care.
Thank you.
Thank you so much. Take care.
Thank you.
Stay safe.
Bye.
Thank you.